Over to you, Vivek.
Good afternoon, everyone. I am Vivek.
Good afternoon.
Good afternoon, sir. I am thankful to Inspire Dental team. They really worked very honestly. And when the controversy was started on the WhatsApp and the Facebook, and you know, when they're typing on the Facebook and posting the message on the WhatsApp, some emotions comes out, and then actually maybe some bad words and all the things were happening. So the other thing, you know, if you really believe in your system, and how you are going to believe in your system, what you are practicing by going through the literatures and everything, because in the end you are going to be responsible for the patient, nobody else, okay? And all your 10 or 20 of mentors whoever taught you, but at the time when you are operating, means you have to use all the knowledge from the convention or from the basal, and you have to put at that moment on the patient, and that's how we treat successfully. Like in 2000, there was a conference was there in Japan, ISOI, and at that time, my first mentor, Dr. Ajit Shetty sir, he was taking the class, and there were 60 odd people were there sitting, and he told actually who all are doing the implants. Only 3 or 4 hands went up, and we were sitting like that. Okay, what is implant? Nothing. He told, wow, all the guys who have not done the implants, you are the best person to be sitting here, because now you are going to take up more from me. And now I have say actually when the debate was there, so I was planning that more conventional guys should come actually. I know actually my basal guys, my strategic implantology people, they are all convinced, you know. But more, the means 90% of the chair should be occupied by the conventional guys. So that we are going to shoot the questions and we are going to tell them, you know. I always say whenever the questions been asked by the respected Udita sir and everybody, I just tell them, you know, please come attend actually our 2 or 3 day session, you know. We show them A to Z of the procedures, okay. And now it's such an honor to share a podium when all the greats are there, like Kumar Swamy sir, Ide sir, Ari Shetty sir. I start up actually. So now, you know, and the best part is when the Professor Ide sir and Lucas have spoken, and this nothing is there for me actually. So it's really my lecture will be so smooth, you know. So basal and cortical bone are like the bone other than the alveolar bone is the basal and cortical bone. Now everybody know, okay. And this bone is highly mineralized. And when we do the static implantology, we are always doing immediate function loading. Yes, in immediate function loading means, and I am going to show you the cases. See, I have started the conventional implant from 2003 onwards, and how I shifted to the basal implantology, because at that time, 2009 end, there was no option was there other than the basal implant for doing the immediate function loading. And then when I gone with the lectures of Dr. Ide sir and all the articles, earlier their articles were there, and there was open access were there. So I started believing it. And there is one very important book is there, who are all actually really want to know about the bone. It's called Skeletal Tissue Mechanics by Martin and Burr. This one book is there, Skeletal Tissue Mechanics by Martin and Burr. When you are going to read it, you will say, come on, this OPG, I can see only the basal bone or the cortical, nothing else I can see. So this basal bone is been actually, it's a highly mineralized zone, and it's formed by the macro trajectories, and macro trajectories are governed by the motion of the by the muscles actually, how the mandible is flexing, and basically by the masseter and temporalis. And these, I'm going to go a bit fast actually, you know why? Because I want to show the cases, because all the theory part, Professor Lucas and Dr. Ide has already spoken, you know. Yeah. And we want to place the implants in the position where actually we are going to have the highly mineralized bone, and where the proper where the proper forces are getting transmitted. And what are the areas are there? They are the buttresses are there. So we want to engage the implants in the buttresses and how that it works. That's the first cortical. The first cortical is the red line, and the other corticals are actually the pterygoids. The first cortical is the crystal cortical. The second cortical, I just want to brief actually, you know, the second cortical, nasal cortical, sinus cortical, and third cortical is always corticals other than the maxilla, actually outside the maxilla, that is the pterygoid and the zygoma and the orbit. Why I am telling? Because in conventional implant, whenever we are placing the implant, we are all dependent on the first cortical only. And first cortical is less mineralized than the second cortical is less mineralized than the third cortical. So why not to use the proper bone? These are the different implants are there. It's not like that we are going to use only the smooth surface implant. Whenever we are having a good amount of plenty of buccolingual, buccopalatal width is there, because patient has come for teeth, patient has not come for implant at all. Agreed. But there are the sites are there where the graftings are more, they have a higher prognosis, but there are the sites are there where the grafting doesn't takes up actually. It's just like for accommodative purpose. You can do the vertical grafting in the posterior mandible, and you can see within 3 years it's going to be resolved. So what is happening? The rough surface implant, the compression screws we are using whenever the good amount of cancerous bone is present, we are compressing it, and that time we are not touching the second cortical. But there are most of the cases where where really they need the rehabilitation, and there the good amount of atrophy has taken place. I can say 60% or 70% of the population is full of atrophies is there, and they really need it. It's not like that, oh come on, I am not going to treat this atrophic cases, because I want to have a good night's sleep. No, come on. You should have some adrenaline actually. You have to hit this patient. You have to treat this patient. These are the patients that are to be rehabilitated. So there are the disciplines has been laid down by Dr. Edesar et al. And what we do lingual and vestibular cortical engagement. My slide was to tell actually the other professors also and the other lecturers how we do it. In posterior of the mandible, lingual cortical, we are not going, we put our finger actually. I always say, I am criticized by this statement, but I always say, my professor has taught me, seeing is believing, or your finger is your CBCT. Your fingers are your CBCT. You have to run your finger everywhere. You just have to run your finger everywhere, feel it actually. Okay, facial artery is there, of course facial artery is there, clench it, feel it. The pulsation, you are going to get it. You are going to avoid that area. Between intermental foramen, of course, you are not going to perforate at all. The lingual anastomosis is there. Posterior, where the triangular projection is there of the myeloid action. What the myeloid undercut is there. There is no arteries, nothing is there actually. The artery is not touching the mandible or the bone actually. It is minimum 1 centimeter away. It's all in the tongue area. But there are the lateral lingual canals are there at the first premolar or second premolar region. That area you have to be very careful here. So this we know, that's why we have started operating. The fear factor was not there. Fear factor was there when in the 3rd year BDS we were told to put the infraalveolar nerve block. All the contraindications, all the complications we are thinking what's going to happen. What our professor taught us, you have to feel the bone. Feel the bone with the needle, aspirate and then inject. So there is always the safety parameters are there. This is the buccal, this is the lingual cortical engagement, you see. These are the lingual cortical engagement. Why the implants are coming out? Why it's not like they have to just touch the cortical? Why the implants are coming out? Because you see the threads are there. These threads has to engage the cortical. Because if the threads are not engaging the cortical, when the extrusive force will take place, the implants are going to move. So when the threads engage in the cortical, then not for the intrusive or not for the extrusive forces will be there, and the implants are going to be stable. This is the buccal bypass. That means actually the buccal cortical engagement is there. Now, why we want to place the implant tilted and engage actually? Why our implants are tilted in the anterior region? You know why? Because we want to place our implant and to reach our implants a more mineralized area. The more we go into midline of the mandible, the more highly mineralized bone we are getting. And why the implants are tilted? Why we are not placing straight implants? Why from the premolar we are going towards the anterior? Because it reduces the pontic span, unsupported pontic span. That's why. Why we are placing implant not at 6 region, at 7 region? There actually the pterygoid muscles are attached. There the linea oblique is there. Highly mineralized bone is there. So our strategy is to place the implant first, and then you are going to design the occlusion or design the prosthesis. Cortical in the anchor is in the floor of the nose and palate. Yes, we are not coming out in the nose actually. Okay, we are just engaging the cortical. It's not like that. The joke is there in the Facebook or in the WhatsApp. These implants are all in the nose and the patient can feel it. Earlier when we were teaching, you used to joke, okay, implants, how come you will be sure implants are in the nasal cavity? Use a small finger. Put it. But it was a joke actually. You are not going to do it at all. We have a dedicated perforation is there. With 2 meter chisel, we perforate the cortical. That is the length we are using, and we engage the implant. How come you know we have engaged the implant? Engage the proper bone. Just by the insertion torque. What is our insertion torque? Nothing less than 60 Newton. What is the maximum? At 110 Newton, implant fractures. Okay. So this is sphenoid bone. How we are going to, we are engaging the pterygoid bone. Now the big question Aditya sir has asked it. You are just going blindly and placing the implant in the pterygoid without respecting the anatomy. Sir, there is the thing is there. This is the pterygomaxillary fissure. From the pterygomaxillary fissure, 1 centimeter superior to pterygomaxillary fissure, there is the internal maxillary artery is there, and buccal the ganglion is there. We are always actually placing obliquely towards the palate. And how? This is actually, we places the implant between the body of the sphenoid between the lateral and the medial wing of sphenoid at the body of the pterygoid. This is the proper area. So that's why whenever the criticism is there, whenever the discussions is there, I always ask them politely, just please come for 2 or 3 day visit, in our course. A to Z we are going to show you everything here. Or we can operate in your clinic to show you A to Z. And why actually I am using more of single piece implant than the 2-piece implants, because I had the experience with the 2-piece implants. Means the abutment screw fracture was there, and you can say it's maybe because actually you are not using the proper implant, the right implant, the high-end implant, high quality implant, or maybe the prosthetics or the lab persons were not proper. But sir, I am going all over India in the rural places. I go there, I operate, I am there for 3 days, I train the technicians also. Yes, our idea, the concept of aesthetic implantology is everybody should have, means whoever the need of the implant is there, the atrophic jaw is there, they should be treated. They should not be left, and our implants are not so costly also. Everybody can afford it. So this was a diagram is there, where actually superior to the pterygomaxillary fissure, we never approaches the superior to the pterygomaxillary fissure. This is the case of Dr. Edesser. You can see he has placed the double pterygoid. Why the double pterygoid? The single pterygoid implants were started by 1989 by Paul Tulane. He was actually the first person to place a pterygoid implant, but why not the double pterygoid? If you are getting a good, highly mineralized bone is there, why not the double? Why not the 3 pterygoids? You can see that. You can see how Dr. Edesser has operated. He has went from the first molar region, but he's kept his implant blow down actually from the pterygomaxillary fissure, because we are concerned of the patient actually. We are not doing anything blindly. Maxillary sinus, palatal to the maxillary sinus, yes, this is an example is there. And we really believe in no cantilever. We are against the cantilevers. You know why? Because all-on-4 principle, it has come, it is a modified principle of all-on-6, what was done by Dr. Brainmark. And he mentioned 4 implants in the anterior and the most distal implant only 15 degree calculated. Now that the studies have come, if you are having more than 35 degree of angulation will be there. What's going to happen? There's going to be the stresses are going to accumulate at the first cortical part or the crystal cortical, and strains are going to accumulate at the cancellous part. And you are going to have either if the processes, if the lab work is really, really nice, you're going to have an implant failure. And if your lab work is not good, what is going to have? Of the junction, the prosthetic failure will be there, abutment screw fracture will be there. So anything tilted more than the 35 degree, it's going to have I'm talking about with the cantilevers. If you are having a cantilever, then anything tilted more than 35 degree and the patient and the process having a cantilever are going to have a failure of the distal implant. Okay, this is the simple cases there. Now I'm going to show up the cases. Okay, I'm not going to bore anyone. The simple cases there. Come on, it can be done by all-on-4. Yes, I agree. Maxilla, I doubt actually, because in maxilla, either you have to give, if you want to do with the convention, immediate, I'm only talking about the immediate functional loading. I'm not talking about the delayed loading and single piece implants. So yes, you can do the zygomas, and then maybe one implant you can engage at the nasopalatine foramen region, and then you can restore it. But for us, what we are doing actually, we just place double pterygoids, 6 implant in the anterior, and these implant in the mandible, and see the double pterygoids, the nasal cortical engagement, lingual cortical engagement, but between the intermental foramen I have not engaged any cortical because there is no need to. This is a highly mineralized zone is there. This is the horizontal buttresses is there. There are the slip lines is there. What are slip lines? SLIP slip lines. Your all augmentation procedures are based on the slip lines where the mineralized zones are there. The slip lines, if you are going to place actually the augmentation material on the slip line, then the bone is going to catch up. It's not going to catch up, you just want to put powder anywhere else. And that's how. The slip lines are the mineralized zones are there created by the trajectorial forces. So you have to feel the bone. what is happening in, and what I was doing actually earlier, I am not talking about others, what I was doing earlier, I was placing the implants like a robot. Drill 1, drill 2, drill 3, place the implant, very good. But now what we are doing, we just go, we feel the bone. After the feeling of the bone, we know actually where the Mendel's zone is there, and we place the implant. Completely flapless. Metal to plastic, now come on, so much of foot impaction will be there, everything will be there. Sir, what is my trick is there? My trick is from the pterygoids or from the distal implant to the mesial implant, what I am doing, where the large pontic span is there, I have always created sanitary prosthesis. 3-meter clearance is there, always 3-meter clearance is there, and I am going to show you the prosthesis. It's a self-cleansing prosthesis. We have an overhang. Overhang is also not there, you can see. No overhang is there. But what we do, we always posterior area, we create a sanitary process, and always a space is there at the palatal aspect or at the lingual aspect, so the patient just clean it. Okay, that's the slides of double pterygoids. I will just go it fast. The good cases are there. Lingual cortical engagement. Like canine region, you can see I have not touched any of the cortical. There the Mendel's zones are there. These implants, okay, they are not going all over the nose. Pterygoids. This is another aspect how we do actually. We do nasomaxillary buttresses engagement. We go from the palate and we engage the implant here. What is doing? We are doing actually we are leaving cross-arch fixation, but we are creating a tripod also. If the one implant is gone from the buccal to palate in the anterior region, if other implant you are going to place from the canine and engaging the nasomaxillary buttress area, it really gives good resistance actually to the lateral forces. This is like that. Okay, now come the cases where now these all the bone cases. The one more thing is there when Udita sir was saying that these type of the cases, these are the cases can be done in India, but it's not going to be done actually anywhere else, because here in India the law is not strict. No, come on, it's not like that. India is like that. There's no restriction, means if something is not according to the protocols, but protocols, who is defining the protocols? Okay, it is like that. If something is there that is not harming the patient and is going to improve the quality of patient, India is readily accepting it. All over the world it is getting accepted. Then they say about the FDI. Okay, there are countries are there other than the USA also actually. Okay, the Britain also. I have operated in Britain also, no problem at all. The patients were there when I operated in Britain. All the failed implants were there. They were just saying actually, okay, I know actually you can't operate in Britain, but we are taking the responsibilities. Please come and operate, because they want to improve the quality of life. And in Europe and Russia and everywhere, this system has so picked up because it's so friendly to the patient. And these are the cases are there. Okay, let's start the cases. So how we are going to do it? You may be actually going to reflect the flap, but why you are going to reflect the flap when the surgeon, the oral surgeon, he's a very renowned oral surgeon, is here, Dr. Deshmukh. He has done such a nice grafting. And microvascular surgery he has done, he has picked up so nicely. Why you are going to again put an incision on these cases? See, I did the flapless. Flapless engagement from buccal to lingual event to avoid actually the screws, the bone screws were there. But another thing is, just note it down. I always create 3 millimeter, minimum 3 meter of clearance I am giving, because I don't want to touch the soft tissue. This soft tissue I am not going to touch it. In the anterior and the posterior. Now, how come we can do the nerve bypass without, CBCT is there, but of course actually I have not gone through the CBCT, but CBCT is also present, but how you can do it actually? I am going to show you. One slide, single slide I can show you. Okay, sir, these are the burnouts are there, Udita sir. These are the burnouts. So these burnouts are the prefabricated are there. So over the lab analog, they get it fit. That's why we are getting a proper fit is there. But 0.25 millimeter of the clearance is also there for the cement. It is not like the lab person is actually just making something over the lab analog. We have the prefabricated everything of the parts are there. Now why? Why this metal? Why this metal is there? So much of metal is there. Because first we have placed the implant, now we think about the supporting polygon. I am going to go with the supporting polygon. Means actually you have to create a bilateral symmetrical space for the tongue. That's how we are going to design the prosthesis. This is the supporting polygon. Our idea is the forces are to be transmitted all intrinsically, means the vertical forces are going to be transmitted. We have to restrict the forces, lateral forces on the T. That's how our system is going to succeed. Any of the implant or any of the bridges, how we are going to succeed. We have to restrict the lateral movements. This is the prosthesis, self-cleansing prosthesis. This is not an open bite actually. This we have taken the picture, you know. After that, what is our trick is there? First of all, we have to fix the process. Always a 2 to 3 meter margin is there, because these patients, these type of the patient, they have uncontrolled movement of the mandible. What do you expect with this patient? So we have to give some space. We have to give some space for the correction of the prosthesis. Okay. Now that looks all boring now. Yes, the mandible. Yeah. See, these are the screws. One slide is there. Yes, these are the bone screws were there. So that's why I went from the buccal, to lingual at the grafted site to avoid the screws. Other cases also there. See, these cases doesn't have money to pay, because they already have paid everything for the reconstruction or for the surgeries and everything. Okay, so these cases are so good cases are there to operate. First of all, they doesn't have money, but the second thing is that it gives you pleasure to treat these cases. What are you doing? Placing implant in the 6th region, 1 or 2 implant, and then you're taking 3 or 4 pictures of the nice ginger color have done. You know, these cases make me happy actually. These cases, okay. See the restriction. And this case was done. This case was done on the clinic of Dr. Rohan Virani, and I'm very thankful to him that he has given this case. He always called me. He always called me when such type of cases are there. So I don't want the bone cases. Please give me these type of cases. Okay, it makes you happy, you know. See the movement. And this how you can see this is the immediate post-op is there. So this was very hard to place the implant here. So you can see the radiolucency. Now the radiolucency is there, and these basal implantologists, they are crazy guys. They say the radiolucency is there, the bone is going to pick up. How come this implant was mobile? And they say they have to clear the occlusion that side. No, if you are making where the implant is mobile, if your implant is mobile, means it is not infected. First of all, there is a word is there in the orthopedics. It is called sterile loosening. Understand the term first of all before quoting in the Facebook or WhatsApp. If you are going to make it, if you are going to load the occlusion from this side, what is our thinking is there? You are going to again create a trouble, because then the disuse atrophy will be there. You have to load that area. 1 year post-op. It's all healed. The occlusion. Now how the occlusion will be, occlusion is going to be very tough. So how we have done it? We have not given any cusp actually. Patient, the mandible is sliding, you know, free of any restriction. And how the movement of the mandible is there. There the muscles are there, and the bone is actually, the condyles was in the right hand side. He used to first of all hit the right hand side and then click on the left hand side. So this type of patients, we need lots of follow-up. This was the case was done. Malignant melanoma was there, taken out. But then what is left? The patient say, now this is actually what Ayush Shetty sir has also pointed out. You know, just for the sake of implant placement, you cannot take out all the teeth. You have to respect the natural teeth. So what I have done? I placed one zygoma implant, nasomaxillary buttress engagement, and 2 implants. And that's how we have done it, and patients very happy. The other case, the trauma happened, and you can see they have placed the bone screw in the canine only. Okay, the impacted canine was there. How it has been done? I was having the zygoma, I was having the nasomaxillary buttress was there, or and that thing, you know, the nasopalatal foramen, the nasal spine. Sorry, the nasal spine was also there. Good bone, you know. So much of bone is there. Don't worry at all. It took 1.5 hours to take out the screw, and just you can say half an hour to place the implant. That's a zygoma implant. Now the question is how much you can bend the implant. Our zygoma implants we are bending around 75 degree, 80 degree. I didn't calculate actually. You can see. Upper we have gone metal to plastic, the lower ceramic. Okay, this is like post-op, and this is all artificial, okay. Now I am going to come up with this is just a 2 weeks later, and after 2 weeks, again, see, this is like the opening is there, that was not my job. I told my patient to go to the oromaxillofacial surgeon and cover it, but he didn't do. So what now he's doing, I was laughing at what he is doing to block that space. Okay, this was the case, zygoma, okay, and engagement. The implant, this implant, when we see we have done the canine bypass, come on, how you are doing the canine bypass? The canines are always placed buccally. There's so much of bone is there palatally and the lingual cortical. You can bypass it very easily. You can see. And now these cases, come on, you doesn't have a follow-up. These cases might have fallen down in 3 days, 4 days, 6 days, or the implants in 3 days, and it's fallen down in 6 weeks, or fallen down in 30 days. No, it's not like that. Otherwise, I am responsible. We are responsible to a patient. Okay, all the question will be asked. Okay, this is the follow-up is there. That is the follow-up. And now the clinical pictures. I always try to give the sanitary thing. Okay, and here the resorption has happened. 3-meter resorption has happened. Patient is all the foot go in and out. Actually, patient is very happy. And what he does for the blocking of the for the foramen, he put some elaichi. I don't know the English word actually. So I was saying, what is happening? What is there actually? I took a picture. The other case. Okay, the case was done in Mumbai only. Yeah. So they say the bone is not there. The bone is not there. I see so much of bone is there. The pterygoids are there, the zygomas are there, and the corticals are there. Double pterygoids, zygoma, and we can complete it. And this self-cleansing prosthesis, highly polished. This case, I didn't find out the pterygoid. It was not possible for me to place the pterygoid, and it was operated for ossifying fibroma. So the bone condition was not highly mineralized. So I couldn't be able to bend the zygoma. So this was also done in Mumbai, but still, actually, we have just placed the metal bar, and the process we have done it, but I think I'm going to wait for 1 year at least before I'm going to change the processes. This case was done of one of our seniors in the clinic, Dr. Viren Kumar. It was done like more than 1.5 years, around 2 years or 1.5 years back actually. This was the case. This was my first case to operate actually such type of cases, and the good grafting has taken place. But it was operated in Bangalore. And you know, from airport, if you come to Bangalore, there are already 2 hours in your taxi. Okay, so good traffic is there. So that means you can plan your treatment. You can do your treatment planning. So treatment planning was suddenly the idea came. Why not to splint the native mandible? It's already splinted, but why not to augment this splinting? So what I did, I placed this was the clinical picture. So I placed the zygoma implant in the mandible. So I just messaged to Dr. Edesa, I placed a zygoma implant in the mandible. The reply was, what? Oh, come on. And then he was happy. So I planned actually for the 2 zygoma implants in the mandible, but couldn't able to do it because I was also inexperienced actually. These all the cases I am getting, my experience is increasing. But if you are going to ask me if you have 5 or 10 years follow-up, see now it is like a gradual step is there. First of all, they have started recognizing me that I can operate such cases. So these cases have started coming to me. It's going to mean the more the recognition will be there, the more the atrophic cases will be there for me. Okay. So right now I'm not having actually more than 5 years, 6 years of post-op cases are there, follow-up cases. But for me, if any case survive for more than 6 months and better than 1 year, that means the primary mineralization, the secondary mineralization has taken place. Now only because if you are not good in occlusion, you can lead to a failure. Otherwise the bone has done with the implant. This was after 1 year. We have changed the processes. So one implant was engaged. It was too close to this thing. The screw. That's why one of the implant got failed. That's why the first case what I showed you. This was my experience. I thought, yeah, because of that, my implant was touching the screw. I had one failure. That's why the first case what I showed you, I went from buccal to lingual because this is my experience there. I'm having my means I'm gaining my experience by my failure only. So this was my failure. One implant I have to remove it. Now, the finger is your CBCT. Come on. See, I'm going to show you. This is Coward-Howell's classification. Mug up this thing. Where the nerve is there, artery, first of all, the artery is superior than the nerve. Thumb rule Lewis, we are placing the implant only in infiltration, never giving the block. We are never infiltrating at the mental foramen region. Second thing is, run your finger. Wherever the ditch will be there, it is always buccal to the nerve. This Prosthetic classification, it's showing just atrophy. So, initially when I started the nerve, engaging the bypassing the nerve, what is the nerve bypass? It is like that. We places the implant, engage the lingual cortical, and then the OPG comes. Suddenly we find out, oh, the implant has bypassed the nerve. The nerve looks superior. We say, oh, we have bypassed the nerve. That was not intentional actually. It was happened actually. We just placed the implant lingual cortical. Sometimes maybe the nerve is coming superior to the implant, but this is the true sensor bypass, and we are doing the buccal bypass. How? This was my first case was there, so I have to reflect the flap. I reflected the flap. That's okay. It's all boring. See, this thing is a pterygoid and everything. Yeah. So I opened it. You can see this was my first implant I was placing. I perforated. First of all, I put my thumb and felt actually where the facial artery is there. And then I went and perforated the cortical. But when I was placing the implant, the atrophic mandibles, the mandibles are all hollow inside. There's nothing is there. Just go dip. Then you have to find the other bone. It is always when we place the second pterygoids. We go all transsinus. There is a dip is there. You have to go all inside the sinus cavity, and then you have to engage the pterygoid. So, but it comes with experience, no problem at all. So this was actually my first case. I couldn't able to engage the second, the cortical, and then the other implants I've engaged it. So what is happening? I'm going to show you. This all bypasses there. This is, you can see, the corticals has been perforated. You will say, oh, come on, you have fractured the mandible. No, if I have fractured the mandible also, I have done the splinting also, you can see. Yeah. It's healed. Healed means actually it's like like 2.5 or 3 years post-op is there. The other part of these patients are in what is the what's not a good part of these patients, you know, when these all atrophic patients are there, we felt so happy to eat actually. They are now coming for the follow-up also. So you have to call them, see, your implant may be mobile. Come on, doctor, what you are saying? I am having right now butta, you know, anything I am can have it. So you have to call that patient. This is the, and I'm from a small town, Eta actually. In that place, if I was operating my implant, I would have done hardly maximum 50 implants in 16 years. Okay. So what is my 99% of the cases are there as a consultant. I roam, I just drive my car all over and fly actually and operating. So getting the follow-up is very difficult for me. But definitely when the failure is, the follow-up will be there. No problem at all. He is going to complain. The other case, okay. Now I want to show you one more thing. You all guys are so expert in sinus lift. You know, you just reflect the flap. After reflecting the flap, you can know, because I have done also sinus lift a lot. You reflect the flap. After reflecting the buccal flap, you know there is the this is the means bluish hue will be there when then the hollow cavity is there. So when in the atrophic cases, you are going to get the bluish hue also, because superior to the artery, superior to the inferior canal, there is actually the pores, more pores will be there. You have to appreciate, reflect the flap, make dry the area properly. You are going to appreciate the anatomy. I will just show you. Okay, this is the part, but yeah, it's not so clear actually. Maybe here the artery, here the inferior canal is there. So there are lots of bluish hue was there, and the pores were there. You can easily appreciate. This is the nerve is there. Seeing is believing. What my professor had taught me. Okay. Now other case. Yes. This case actually, these are not walking patients are there actually. These patients have been all rejected by the conventional implants, and I am not in a position to place conventional implant. That's why I am doing the static implantology, and I am addicted to static implantology because the patients are so happy. So whenever the doctors are coming who are joining our course, and they say, hey, come on doctor, I have some 1,000, 2,000, 3,000 implants I've done. And sir, now I'm more scared of you actually. Now you have to attend. You have to attend this course. If a person has come. He has not done any implant. His mind is fresh actually. He knows only one bone, cortical bone, nothing else. So you have to unlearn the things before learning. Okay. So yes, that was the patient. Okay. Yeah. This was the crisscross bypass was there, buccal and lingual. This is a prosthesis. Now we have to manage here. It was not good actually. We have done actually lots of correction. You are right actually, because in this patient the recording was not proper. I am going to show the proper one, because you can have any day actually, you can, because these are the all coarse patients are there. In the coarse patient, why? Whenever the atrophic cases are there, they know Vivek is going to operate in the course. You know why? Because the patient can't pay, and for the course we are doing in a negligible prices. But we have improved the quality of patient. You can ask this patient how happy they are. Other patient, yes, okay. All flapless. Everything is flapless. Bypass is flapless. This was buccal cortical, buccal cortical, buccal cortical means the base of mandible, and this was lingual cortical. Maxilla. Means we know how to do phase per transfer. We know everything. Okay, we know. Okay, and these are the processes are there. Okay. See the supporting polygon. See the supporting polygon. These are the cases. Yes, we have fractured the mandible multiple times, you know, see. But patient is very happy actually. Because the OPG is giving you two-dimensional figure actually, sir. Earlier when we were placing the pterygoid implant, in the OPG, the penumbra plane is like away from the pterygoids. So everybody used to say, hey, come on, how your implant is there? In the soft tissue, what the hell you have done? Yes, in the soft tissue we got the insertion torque of 70 Newton. I don't know why. You have to get the CT done to know where the pterygoids are there. Another case, you know, these cases, it makes you happy, you know, these type of cases. See, you can see the implants. I have not bended the implant. I can't dare to bend this implant. I will fracture the mandible. This case is done in the clinic of Dr. Ashutosh Chaudhary, and he is sitting there. He has come to support us. Thank you very much, sir. Now you see, whenever you do the buccal cortical or base of the mandible, you can feel this. First of all, I have started learning the lingual cortical engagement. Now you know we are proceeding towards a more mineralized area where the more insertion torque we are going to get. So now we are turning up towards the buccal cortical engagement. Yeah, maxilla. Okay, come down to maxilla. You know, good amount of bone is there. You know, in the maxilla. This case, I doesn't have any. No complaints are there from my colleague implantologists, because they have already given this case to me. No competition is there at all. Yes. And now see, this is the CT, this is the OPG. What you want to view? I hate CTs. See, it gives you nervousness. Okay, this, oh come on, this white line is there. You can manage, don't worry. How we can manage? Pterygoids, zygoma. Because it can be managed without zygoma also. But the high end, I just operated in a super special hospital in Delhi, and the patient and the doctor was, no, you have to use the zygoma. Okay, ma'am, let's use the zygoma, no problem at all. And this was her implants, you know, it was advised for me not to touch this implant. Yeah? So this implant will be there. That was zygoma. See, we can bend the implant. Okay. Now we have a vertical atrophy was severe. Severe vertical atrophy was there. You can check it. Sanitary prosthesis, you can see in the posterior. Now, these are the cases, they are going to, yes, sir, I am just coming, sorry, sir. These cases, come on, these cases, what I have shown you, is so atrophy is there, how these nails are going to engage, some sort of a bone is there, 1 meter bone is there, and why you are placing 10 implants, 20 implants, or 6 implants? Because bone to implant contact area of the bone is less when you are engaging the corticals, because only the corticals engage. You have to increase the number of implants. And this implant, this is the post-op. This was done actually in Mumbai only, and the Dr. Twinkle is also sitting here actually. Thank you very much, ma'am, for giving me such a beautiful case. And this was the case. But it has to, this was the pre-op. But this case, now this is 6 months, a post-op is there. 6 months, it has taken up actually, I am very sure it is going to last long. Yeah, these are the follow-up cases, they are boring cases when you have good amount of bone is there. Yeah, 3 years follow-up is there. Anterior, you know, when the atrophy is there, you can build up the bone also, but the patient opted me actually for immediate loading, you can do it. You just have to go from the palatal. Other kinds of prosthesis also is there, metal to ceramic. Nice prosthesis. Thank you very much, sir. Thank you.